Assalamu alaikum. Let's discuss about preterm labor and labor. Before jumping into the topic, look at this. Look at the hand of this patient. There is gangrene. Can you tell me the diagnosis of this patient? Okay, if you know, put it in the comment box. Preterm labor. What are the risk factors for preterm labor? Prior spontaneous preterm delivery. Prior spontaneous preterm delivery, if there is multiple gestation, if there is a short cervical length, if cervical length is short and there is cervical surgery, cervical length is short, cervical surgery, and there is cigarette smoking, cervical length is short, cervical surgery, and cigarette smoking. Screening and prevention: cervical length measurement by transvaginal ultrasound, progesterone administration, cervical length measured by transvaginal ultrasound, progesterone administration, and cartilage placement. Strongest is a preterm delivery in a prior pregnancy. Strongest is preterm delivery in prior pregnancy. Look at this picture. This is the cervical cone biopsy taken for if they are to rule out the cervical cancer, and one of the risk factor is cervical insufficiency. So if there is cervical surgery, then there is chance of preterm labor. A negative fetal fibronectin test prior to term is an indicator of low risk for preterm delivery. A negative fetal fibronectin test prior to term is an indicator of low risk for preterm delivery, and high negative predictive value fetal fibronectin levels are high up until 20 weeks of gestation, and they are not a reliable and thus are not reliable marker of preterm delivery in early pregnancy. So it's not a reliable marker for early pregnancy, but if it is done just prior to birth, and it is an indicator of low risk preterm delivery. Look at this chart, very high yield. There is another chart. If there is preterm, uh, how we can prevent preterm birth. If prior preterm, yes, prior preterm delivery associated with painful contraction. If pain, if yes, prior preterm delivery associated with painful contraction, yes, prior preterm labor. That means a regular contraction causing cervical changes at less than 37 weeks of gestation with intact membrane. This is called preterm labor. If there is prior preterm labor, give progesterone, IM, or vaginal. If prior preterm delivery associated with painful contraction, no painful contraction. If there is cervical insufficiency, prophylactic circulation should be given. Prior preterm delivery, prior preterm delivery, no prior preterm delivery. Second trimester transvaginal ultrasound for cervical length. If normal cervical length, routine care. If it is incidental short cervix less than 2.5 centimeter at less than 24 weeks, give vaginal progesterone. Give vaginal progesterone. So prior preterm delivery. If prior preterm delivery, yes. Prior preterm with painful contraction, yes. Prior preterm, if there is a pain, give progesterone. If no pain, prior preterm delivery, associated with no painful contraction, then cervical insufficiency, go for prophylactic circulation. Prior, if no prior preterm delivery, second trimester transvaginal ultrasound for cervical length. If normal cervical length, routine care. If it is incidental short cervix less than 2.5 centimeter at less than 24 weeks, vaginal progesterone should be given. What is the first step in evaluating? What is the first step in evaluating risk of preterm delivery in patients with history of cervical surgery? If there is any, if there is history of cervical surgery, if there is history of cervical surgery, cold knife conization, transvaginal ultrasound measurement for cervical length in the second trimester, transvaginal ultrasound of cervical length in the second trimester. What is the recommended management for a pregnant patient with no history of preterm labor and short cervix? No history of preterm labor, short cervix on transvaginal ultrasound. Vaginal progesterone should be given. Progesterone maintains the uterine quiescence and protects against premature rupture. It protects the prom. If there is short cervix less than 2 centimeter on TV US, give progesterone, vaginal progesterone. Cervical insufficiency. Cervical insufficiency, it may be collagen defect, it may be uterine abnormality, collagen defect, uterine abnormality, cervical conization, and obstetric injury. Collagen defect, uterine abnormality, cervical conization, and obstetric injury. Clinical feature: two or more than two prior painless second trimester losses. Two or more than two prior painless and a second trimester losses, and painless cervical dilatation. Management is sarclage placement, visible cervical dilatation, and no uterine contraction. This is normal cervix and closed normal cervix and long closed cervix. This is short and dilated cervix, short and dilated cervix, amniotic sac bulging at the os. There is sutures. This is sarclage. In patients who are in patients who have bulging prolapse or prolapsing amniotic membrane, a rescue sarclage is not typically recommended due to high risk membrane rupture complication, intraamniotic infection, cervical trauma, or likely imminent delivery. Preterm labor management. Preterm labor, maternal instability, intrauterine infection, and fetal distress or demise. Maternal instability, intrauterine infection, fetal demise. Yes, immediate delivery. If preterm labor, maternal instability, intrauterine demise, and intrauterine fetal demise and intrauterine infection, yes, go for immediate delivery. If it is less than 32 weeks, four things should be given: antibiotic, that means penicillin, antenatal corticosteroid, corticosteroid, um, tocolytics, indomethacin, and magnesium sulfate. So antenatal corticosteroid, penicillin, tocolytic, APTM, apartment M, APTM, apartment M. Antenatal corticosteroid, penicillin if GBS, tocolytics, indomethacin, and magsulf. Then the ABT, antenatal corticosteroid, penicillin, and tocolytic, nifedipine for 32 to 34 weeks, nifedipine. If it is more than 34, that means 34 to 37 weeks, then AP, antenatal corticosteroid and penicillin if GBS are unknown. So very preterm, moderate preterm and late preterm. Very preterm. Apartment name, moderate preterm, APT, and late preterm, AP. Very preterm, antenatal corticosteroid, penicillin if GBS, then tocolytics, indomethacin, and Maxsulf. Moderate preterm, antenatal corticosteroid, penicillin if GBS, and tocolytics, nifedipine, and late preterm, antenatal corticosteroid and penicillin if GBS. Maxsulf is given less than 32 weeks for neuroprotection if birth is indicated, and decrease the risk of CP, it decreases the risk of CP, cerebral palsy. Tocolytics, indomethacin, nifedipine, terbutaline. Indomethacin preferred if given with Maxsulf. Nifedipine and terbutaline. Indomethacin contraindicated after 32 weeks due to risk of premature. Indomethacin after 32 weeks due to risk of premature fetal ductal atherosclerosis. It can also cause decreased renal perfusion and fetal oliguria and can result in oligohydramnios, hence not given for more than 48 hours. 30 years old female that has gone into preterm labor 32 weeks. The patient has given a drug to attempt to slow down her labor. She is given appropriate pharmacotherapy to promote lung development. So steroid is given, pharmacotherapy, tocolytics maybe. An hour, 2 hour later, fetal heart rate of the woman increases significantly. Oh, what is the mechanism and what is the cause? Nifedipine. After 30 in 32 to 34 weeks, we can use tocolytic. We can use nifedipine as a tocolytic. Nifedipine can cause arterial dilatation. It can cause reflex tachycardia. It can cause reflex tachycardia. Okay, next. Now, liver has three stages. The first stage is when the neck of the womb when the neck of the womb cervix opens to 10 centimeter dilated. When the neck of the womb cervix opens to 10 centimeter dilated, this is the first step. Second stage is when the baby moves down through the vagina and is born. It's the second stage. And the third stage, when the placenta is delivered after birth. So first stage of labor is when the neck of the womb cervix opens to 10 centimeter dilated. When the neck of the womb or cervix opens to when neck of the womb or cervix opens to 10 centimeter dilated. This is the first stage. Second stage is when the baby moves down through the vagina. When the baby moves down through the vagina and is born. And the third stage is when the placenta is delivered. And, and the third stage is when placenta is delivered. Stages of normal level. Stage 1, latent, 0 to 6 centimeter, less than 20 hours for null gravity and less than 14 hours for multi. Stage 1, active. Active stage is 6 to 10 centimeter, and stage 2 is 10 centimeter to delivery. So stage 1 has latent and active stage. 0 to 6 centimeter is latent stage, and 6 to 10 centimeter it is active phase. This is stage 1. And for stage 2, 10 centimeter to the delivery, 3 hours for Nali, 2 hours for multi, 3 hours for Nali, 2 hours for multi. If it is full dilatation, 10 centimeter dilatation, then stage 2 is 10 centimeter dilatation to delivery, 3 hour for Nali and 2 hour for multi. Okay. Okay, now stage 3. Stage 3 is fetus to placental expansion. Stage 3 is fetus to placental expansion. It is less than 30 minutes. Okay, false labor versus latent labor. False labor is timing is irregular, infrequent, and latent labor is regular and increasing frequency. Strength. False labor is weak and latent labor is increasing in intensity. Pain none to mild, and in latent labor pain is high. Cervical changes in case of false labor. Cervical changes is no. For latent labor, cervical change is present. Cervical change is present. Now false labor is characterized by mild irregular contraction, Braxton Hicks contraction that causes no cervical changes. What is the recommended management for patients that present with what is the recommended management for patient present with false labor? Expected management. Okay, now disorders of the active phase of labor, very high. Protraction, POAC, that means arrest, CS, cesarean, protraction, give oxytocin. Protraction is cervical change slower than the expected. Cervical change slower than the expected, with or without inadequate contraction. In arrest, there is no cervical change more than 4 hours with adequate contraction, and no cervical change more than 6 hours with inadequate contraction. No cervical change more than 4 hours with adequate contraction, or no cervical change more than 6 hours with inadequate contraction. With inadequate contraction, the active stage of labor typically begins at 6 months of the dilatation with 1 centimeter in every hour, with 1 centimeter in every hour. Protraction less than 1 centimeter in 2 hours. Adequate contraction are defined as generation of more than 200 MVU Montevideo unit in 10 minutes. Adequate contraction are defined as more than 200 Montevideo unit in 10 minutes, measured via intrauterine pressure catheter. It is measured. Adequate contraction is measured via intrauterine pressure catheter. Now the second stage of labor. Second stage of labor, insufficient fetal descent after pushing for more than 3 hours in Nali, and more than 2 hours in multi. Risk factor is maternal obesity, mm, excessive pregnancy weight gain, and DM. Maternal obesity, excessive pregnancy, weight gain, and diabetes mellitus. Etiology is CPD, cephalopelvic disproportion, malposition, maternal exhaustion, and inadequate contraction. Cephalopelvic disproportion, malposition, inadequate contraction, and maternal exhaustion. Management is operative vaginal delivery and cesarean section. Operative vaginal delivery and cesarean section. In order to operative vaginal delivery to occur, fetal head must be fully engaged. Fetal head must be fully engaged. In order to operative vaginal delivery to occur, fetal head must be engaged. Zero station, neuraxial anesthesia, epidural anesthesia can lengthen the second stage of labor. not the first stage of labor. What is the most common cause of arrest? What is the most common cause of second stage arrest of liver? Fetal malposition, occiput transverse. Occiput transverse. The optimal fetal position is occiput anterior. Rupture of the membrane when there is rupture of the membrane when there is no palpable fetal body. Rupture of the membrane when there is no palpable presenting fetal body, or there is fetal malpresentation, carries a high risk of umbilical cord prolapse, which can lead to cord compression and fetal hypoxia. What is the recommended management for a patient 28 weeks of gestation with the fetus in transverse lie position? The patient desires a vaginal delivery. The patient desires a vaginal delivery. It is expected management. Most fetus, most fetus in transverse lie, most fetus in transverse lie spontaneously convert to vertex presentation prior to term. Persistent malpresentation may require external cephalic version or cesarean section. Persistent malpresentation may require external cephalic version or cesarean section. This is the transverse lie. This is the non-palpable presenting part and palpable bulging bag. And in here, non-palpable presenting part, palpable bulging bag. So low transverse cesarean delivery, horizontal incision, trial of liver contraindicated. No. Low transverse CS, that means horizontal incision, trial of liver. No. Classic cesarean section, vertical, trial of liver contraindicated. Yes. Abdominal myomectomy with uterine cavity entry, abdominal myomectomy with uterine cavity entry. The trial of liver contraindicated, yes, and abdominal myomectomy without uterine entry. If there is uterine entry, if there is classic CS, uterine entry, classic CS, trial of liver is contraindicated. Trial of liver is contraindicated. Now, digital cervical examination. Digital cervical examination is used to determine the cervical length and fetal part directly overlying the pelvic inlet. If the presentation cephalic bridge is uncertain on the digital rectal examination, if it is uncertain, go for transabdominal ultrasound to confirm the presentation and to determine the safest delivery. Amniotomy, iatrogenic rupture of the membrane are no longer done. The most commonly injured the most commonly injured in the lithotomy position is the femoral nerve and the peroneal nerve. Femoral nerve compress under the inguinal ligament when the hip is flexed greater than 90, which can lead to numbness of the anterior and the medial aspect of the thigh as well as weakness of the quadriceps muscle. Peroneal nerve injuries that are caused by compression at the fibular head against the strip, leading to foot drop and numbness of the dorsal foot. So this is all about the steps of the normal level, arrest of the normal level, and preterm labor. Hope you enjoyed, and tell me what is your diagnosis in the comment box. Okay.